Following what Dr. Finn mentioned this morning, that the SMRI tries to connect the SCMR, we have a presentation now by Dr. Michael Salerno on trends in CMR. So I look forward to hearing this. Please stop now.
That's keynote.
One's for PowerPoint, one for Keynote.
Good. All right. Thank you very much to Paul and Debbie Au for inviting me to come give this talk. I was the program chair for SCMR, and I'm going to talk about some trends in CMR and some highlights from the SCMR 2022 meeting. Here are my disclosures. So our conference this year was virtual. We had 3 workshops, including one on quantitative CMR in the era of artificial intelligence. We had 4 channels of content, and then a couple of things I'm going to highlight from our plenaries. We had a 25th anniversary of our meeting talking about the past, present, and future of MR. Towards the 10-minute CMR exam, which comes into the trend of where things are going, and then talking about delivering value, which is ultimately what we have to do. So we had 1,500 attendees from over 50 countries. And the main focus of this talk is going to be on some of the trends in CMR that we've seen. And these include real-time rapid imaging protocols, multiparametric mapping and fingerprinting, the expanding use of artificial intelligence, quantitative perfusion, particularly in light of changes in the guidelines, and low-field cardiac MRI. And so a couple of the talks that were really well attended. The talk towards the 10-minute CMR exam was one of the most highly attended plenaries that we had, as well as our gold medal talks, and then this past, present, and future. And all of them tell us a little bit about the trends of where the field is going. So our past, present, and future, Dudley Pinnell, brought us back to where we've been. Jeanette talked about where we are currently, and then Sven talked about where we're going for the future. And I think the first couple are really questions of where we're going. What are the main barriers to wider adoption of CMR? And these remain, this is from the SCMR survey. They surveyed the society, the length of time to perform the CMR exam and the study analysis. 48% of people thought that was a main barrier. Availability and access of technology, this still remains a problem. Complexity of the exam, which others have pointed out as well as being a problem. And then the next one down here is reimbursement, which is clearly an issue still in the US. We had 2 keynote speakers that really focused on value and where this fits in. And then our 2 gold medal winners were the Matthias and Matthias show, both past presidents of the society. And again, I think, it falls over this trend. So what are the problems of what we've traditionally thought about with CMR? It's a complicated study, long scan times, expensive, limited access. And Matthias Friedrich was really talking about how do we simplify MR and sort of coining his SMART concept here of simultaneous multiparametric reconstruction techniques, with the idea that can we do this in a needle-free way in the future. And then Matthias Stuber also gives an idea of where we're going for the future, talking about some of these 5D techniques that they've worked on, which can be used for angiography as well as function and tissue characterization. So here, I think this might be the only place that I mention MRA in this talk, so sorry about that, guys. So if you look at the pre-conference workshop, some of the most attended sessions were Future Outlook on Multidimensional, Multiparametric Cardiac MRI. This is clearly a high interest area. And then Advanced Image Acquisition Strategies for quantitative CMR, including both mapping as well as perfusion. And then actually, you guys will be excited to see that phase contrast and MRA imaging was actually one of the most highly attended pre-conference sessions. All right, so these slides are courtesy of Claudia. Claudia gave a best of highlights talk about the science part of the meeting. And so for the ISMRM workshop, the topic was quantitative cardiac MR in the era of AI, and really thinking about how quantitative MR can benefit from machine learning and how machine learning can be informed in quantitative MR. And so this included talks about deep learning related reconstruction techniques, which are gaining more and more popularity, particularly in the case of non-Cartesian imaging or radial imaging, where you can get a significant speed up of time. There was also a focus on how AI is transforming cardiac analysis. All of us who gained a lot of hand-eye coordination by drawing circles are largely not doing that anymore, which is exciting, and really AI has made a huge impact in post-processing. Other topics of interest, stress CMR. There's an interest with a growing emphasis both on the science side as well as an interest from clinicians in being able to measure quantitative blood flow with both PET and MR. And over the last couple of years, an increasing role in valvular heart disease, which is obviously a place, at least when we're thinking about aortic disease, another place to be able to put MRA into the picture. So our science track, again, sort of highlights these areas that are interesting. I'm going to highlight a few of them: the multidimensional mapping and fingerprinting, applications of AI, how do we solve new bottlenecks in CMR, what are new ways of looking at perfusion function and fibrosis. Our multidimensional mapping and fingerprinting, that made up a large component of the scientific sessions, looking at T1 and T2 fat fraction. T1 row is another way of doing non-contrast imaging, and then multitasking and deep image prior for cardiac MRF, which I'll show some results in a second. In terms of AI, some nice talks about how we're going to use AI for phenotyping, and then a very interesting talk by Sebastian Kazurki of how are we doing in AI and MR beyond segmentation. That's obviously an area that we're doing really well, showing some of the pitfalls related potentially to radiomics and other things in terms of how reproducible they may be. And then the talks in fibrosis and perfusion, with a real emphasis on quantitative perfusion, a lot of it driven by work at the NIH, which has made some of these things clinically available on the scanner in terms of quantitative perfusion. And I think the Early Career Awards also, again, follows our trend of where the things are that there's a lot of interest. So if you look at the first couple of these, are all parametric mapping, free breathing techniques, and multitasking. So here's some work of some of the young investigator finalists. This is a technique looking at free breathing and self-gated imaging of function, as well as parametric mapping. One of the other finalists, this is from the Cedars group working with Anthony, was looking at SMS, simultaneous multi-slice, for non-ECG free breathing T1 and T2 mapping. And then the winner of the Young Investigator Award also was in this field of multiparametric mapping, again from the Cedars-Sinai group, showing that you can get T1, T2, T2 star, and fat fraction mapping. So I think the next frontier will be how do we utilize these multiparametric pre-contrast techniques to predict information that we may have previously needed contrast for, or to predict other things that we haven't been able to do before. Another interesting talk, again going with the trend over AI, was the Early Career Award for Clinical, which was from the Oxford group, for a technique using Cine, T1 maps, and T1 weighted images used to make those maps for predicting scar with contrast in hypertrophic cardiomyopathy, and then following in myocardial infarction and viability. One thing I really want to highlight is this Friday plenary towards the 10-minute exam. People are very interested in this topic as we're trying to do things faster, get more studies done on the scanner, really looking at what are the couple of approaches. Is the future going to be real-time imaging? Is it 3D all-in-one? How are AI and other novel technologies going to play a role? And so Lon Simonetti gave a great talk, kind of talking about where we are, and unfortunately, in a lot of times, we still are here clinically of doing 10 to 12 breath holds for function, doing late gadolinium enhancement imaging in breath holds, and studies that are still taking on the order of an hour. And as we know, the longer study both limits access as well as costs us more. And real time, if you think about where we already are, and even some of these things aren't even that new, we can really do this in non-breath holding, using free breathing techniques, using single shot or motion corrected single shot techniques. However, we still suffer a little bit from the fact that not all of these things are implemented in the most sophisticated ways by the vendors. Still some questions of what do we give up in terms of image quality. But again, I think we also need to look a little bit beyond. I believe Jefferson made a comment about it's not just how pretty the images are, it's really the information that we're getting out of them. At this point, a lot of these things have been validated. This is work from Gabby Kapter showing in 400 patients that they actually had better diagnostic confidence using real-time motion-corrected techniques, and it reduced the amount of time for the LGE by a factor of 2. And on some scanners, we can get away now also with denoising and potentially doing these just with single heartbeat techniques. And then more and more from a lot of other people that I see sitting in the room as well, really moving towards more advanced techniques where at this point we can really go to doing these rapid real-time techniques with high temporal and spatial resolution with reconstruction times that are clinically acceptable. Claudia kind of took this the other direction, which is saying, okay, the same start, we're doing these multiple different studies, we're doing this in a very sequential way, so what about just doing everything fast and doing it in 3D? Whether this is steady-state encoding, free-running approaches like multitasking or fingerprinting. Here's some work from Claudia's group showing T1, T2, and cine imaging within a 3-minute scan. Work from Mike Markle as well as Matthias Stuber looking at anatomy and flow using 5D techniques, and then also resolving expiration and looking at both the flow in expiration and inspiration. And then another area that's really becoming of interest is taking these advanced techniques that may not be easily implemented in the vendor's reconstruction and being able to use something where we can get the data out, bring it out to a different server, and then put the data back onto the scanner so that the person sitting at the scanner doesn't really know where the data was reconstructed. And this is nice work from Jesse Hamilton where they're for fingerprinting, where they're using neural networks to do their dictionary, and then they're doing low rank subspace imaging, so being able to get T1, T2 and function. And so here are some results from their group. This DIP technique, which I'll explain, is a deep imaging priors, which results in some denoising of the images, really reducing the breath holds from about 15 breath holds down to about 5 breath holds, while also reducing the scan window. A couple of last topic I want to hit is real-time imaging and an interest in low field. And so with the Freemax as well as with some other groups ramping down scanners, here we can see work from Ohio State, very nice at 0.55T, cine imaging, either with conventional techniques or work from the NIH using spiral techniques. And really one question here will be is whether or not these lower field scanners that don't need as much of a footprint to get set up, don't need a quench fen and can be sighted more easily, can these actually expand access to cardiac MR? And here again showing a patient with myocardial infarction with really nice delayed enhancement imaging. So I think it's pretty clear delayed enhancement in cine will be able to be done very well at low field, and those are still the most important parts of our exam. Another approach on this low field is this deep image prior approach, again work from Jesse Hamilton here where they're doing cine imaging using this approach. And here showing some really beautiful spiral cine images at 0.55T with high spatial and temporal resolution. In the last slide, I had to get something in on cardiovascular imaging trends. Paul asked me to add this in. And it's a glass is half full, half empty. So the good news is that cardiac MR is up by 125%. CT, we're actually up more than CT, although they started from a higher spot, and PET has been growing. Myocardial perfusion imaging with SPECT is more and more reduced, and that's really being taken up more by CT as well as MR and PET. That's largely that. And echo is essentially flat. So if you like thinking about percentages, we're doing great. If you like looking at where these actual numbers are, we're still really dwarfed by echo with CMR. This is actually a really nice paper in radiology, cardiothoracic imaging, that explains some of the data there. So I think the take-home message and the trends of where the field is going, people are interested in fast, simple, comprehensive exams, real-time imaging, free breathing exams, self-gated, increased interest in quantification, multidimensional imaging. AI is really coming in everywhere, and then really an interest in whether or not these lower field scanners will pan out to increase access and maybe let us do some other neat stuff. So I want to thank those that gave slides. A number of the slides are from the plenary lectures directly and from our best of SCMR topic. And then the last thing I want to do is pitch that for everybody who loves coming to the West Coast, particularly in January, the SCMR is going to be live this year in the Sheraton in San Diego. So thank you very much for your time and attention.